So, Melissa, after your case, I would like to share a similar patient with you with almost the same symptomatology with mixed urinary incontinence. She's a 67-year-old lady who presented with mixed urinary incontinence, which has lasted for 5 years. She describes that her urgency is predominant. She's using 3 to 4 pads per day. She was on an antimuscarinic treatment for 1 year, but she got a partial response. On physical examination, her stress test was positive. His urethral hypermobility, as tested by the Q-tip test, was higher than 30 degrees. So she had a hypermobile urethra, and plus she had a grade 2 anterior vaginal wall prolapse, a cystocele according to the Baden-Volcker classification. All other tests revealed normal findings. And on spontaneous micturition, she had 60 milliliters of post-voiding residual urine. So again, a lady with mixed urinary incontinence. How would you approach her at this stage, Melissa?
Yeah, there's 2 different thoughts here. And of course, our guidelines might defer us to just moving forward with even advanced therapies for her urgency incontinence. She's met all the criteria of urgency predominance. She's failed medical therapies. And despite the fact that she has a positive stress test, many would just promote not utilizing any further functional studies and moving forward with something for urgency. However, because of the mixed symptoms and because of these physical exam findings, I believe in this situation with a grade 2 cystocele in a supine position, that doing some further investigation would be mandated. So one of the things in this particular case that I have often found is, although they are not promoting bother with their pelvic organ prolapse, it may be impacting function. And so in this situation, I would advocate for multi-channel urodynamics to really determine, is this something reflective of urgency? Do we see this either with overactivity, or do we see this with sensory urgency during filling? And in this situation, I would counsel the patient that the best practices would involve performing this procedure, not just with her in the position that she is typically, but also with the prolapse reduced, to ensure that there's nothing else that's contributing with regards to her pelvic organ prolapse. Now, in most instances, a grade 2 cystocele would almost be considered in the range of expectations following hysterectomy, following a vaginal delivery. But in this situation, when it's a comorbid condition with all these other urinary findings, I would advocate that this is a really specific technical consideration when you're doing a urodynamics, is to do a prolapse reduction just to ensure that that's not significantly contributing. So I do the study twice, once with the prolapse reduced and once at baseline.
Thank you, Melissa. Yeah. And this is actually what we did for this lady. And now you see the urodynamic study performed. Actually, this is when the prolapse was reduced. And you see that almost a completely normal filling phase, except urine leakage after 300 milliliters of filling with every cuff test or Valsalva maneuver. Now, I also would like to ask your opinion here. In the previous case, we have also mentioned the leak point pressure, the abdominal leak point pressure here. Now, this was calculated as to be 99 centimeters of water. But we know that the ICS does not recommend the solely use of this measurement, and not to actually grade the severity or type the severity of urinary incontinence, just depending on this measurement. But it can be combined, according to ICS, it can be combined with standard ICS testing. This is what we do actually here. So we do not decide only on these parameters, but we also measure the Valsalva point pressures during our cystometry studies. So this lady had a urodynamic stress urinary incontinence as a urodynamic diagnosis, and the pressure flow study seems to be completely normal when her prolapse was reduced. So can I please get your thoughts about the chart, and also how you use the Valsalva leak point pressures in your clinical practice?
So let's start with use of that Valsalva leak point pressure. And I concur that it is a very arbitrary cutoff point to say that below 60, there is an intrinsic sphincteric dysfunction. I think that I agree that most likely when it's combined with your other findings, if there's no urethral hypermobility, then I can be certain that with a low Valsalva leak point pressure, it's almost gravitational incontinence, and that we're going to be mandated to do a procedure, more likely a bladder neck procedure, than we would for mid-urethral slings. So I think it does drive our interventions in that regard, but only in combination with other findings for the patient. So I don't use it as an absolute because it is a very blunt measure, despite the fact that we have, because every situation can be different when we're performing the testing, right? And so we try to standardize it as much as feasible, but utilizing an absolute number, just like some will utilize absolute numbers with urethral pressure profiles, it has to be taken into the context of the patient situation and the other exam findings. So although I do believe it adds value to have it, it does not definitively drive therapy in one direction or another. There was a movement early on to define whether you would go with a transobturator or retropubic sling based on leak point pressures. But I think that has faded to a degree because of the situation where you can't necessarily define that without understanding the context in every patient. This patient is very reassuring that she has excellent capacity, excellent compliance. I think that it is not unreasonable to give her a trial before we embark on surgical interventions of behavioral measures and less invasive interventions. In my practice, one of the things that I might propose is use of a pessary, and we can use an incontinence pessary in this situation, and then a little bit more cognizant behaviors such as timed voiding. 300 cc's, depending on her fluid intake, may be 4 or 5 hours of urine. So as long as she doesn't allow her bladder to overfill, then she may do remarkably well just with an understanding of the time frame at which she needs to empty. And if you combine that with a pessary, then it will give you some real life data. And so this is what I find to be so important. It's almost like a proof of concept. If I do this and reduce her prolapse, give her some support of her urethra, give her some behavioral measures, and she becomes very happy with the outcome, and then decides that she doesn't want to utilize the pessary any longer, then we know exactly what surgical interventions, such as a prolapse repair and mid-urethral sling, will be extraordinarily valuable. So she's already demonstrated to us that she will be successful both in voiding and storage and behaviors once we do an actual surgical procedure. So that would be the process that I would go through with this patient in this situation. The other option, if she chooses to move forward, it's a difficult dynamic in today's environment to move patients away from minimally invasive procedures. Right? We live in a world of immediacy, and we live in a world where everyone wants this to happen immediately. They want to happen today. And so in this situation, I might offer bulking agents, although with the hypermobility, we're probably going to get a diminished response and be back in the same situation with some degree of false hope. But it is something that is so prevalent, at least in my particular environment, that patients will come and ask about these types of agents. But in my hands, it would be behaviors, pessary, incontinence pessary, and then determine the need for surgical interventions after that time.
Well, thank you. You couldn't, describe better, actually, this scenario, Melissa. Thank you for this. Again, I think this is a very good example how urodynamics actually are influencing our decision making. These findings are invaluable. As you have explained, we have built our whole treatment on this urodynamic finding, actually. And different findings easily could change our decision making here. For example, if we diagnosed a very low pressure urinary leakage here, or if we diagnosed detusor overactivity, incontinence here, this would change our behavior completely for this lady who presents with mixed type of urinary incontinence. But I agree. I think to start with a pessary test, to go step by step on this lady together with pelvic floor exercises if she is compliant, and then of course. If she prefers to have a surgical treatment option, I would offer a prolapse repair together, maybe a meteorital sling for her. Now, I would like to ask you about your opinion for this case, also for other cases in your clinical practice, Melissa, about the ambulatory urodynamics. Now, we have actually solved the problem of the patient in terms of the diagnosis. But sometimes in the clinical practice, the office urodynamics cannot explain everything. And in that case, do you have any experience with ambulatory urodynamics? And what is the indication in your clinical practice for ambulatory urodynamics if you perform them?
Well, I wish we had that option, because what I often find is what I term urodynamics mismatch. And this happens, I believe, more predominantly in patients who present with urgency and urgency leakage. But it is a very, very common occurrence that we will perform a multi-channel study and not particularly provoke the same activities that are causing their symptom bother or their incontinence, because we have just a very small defined time frame. It is, as great as it is a tool, still an artificial environment. So putting that patient back into their daily situation where we can remotely monitor what's happening, I believe will give us the most robust information in order to move forward with their treatment. So when I have a urodynamics mismatch now, I believe and trust what the patient is telling me. If they tell me that they leak with urge and that they have a frequency where they feel they need the urge to urinate every half an hour, but I see that they have stable filling on their urodynamics, I just believe that we're not replicating whatever it is that is causing this in this particular setting. And in that situation, ambulatory urodynamics would be extraordinarily valuable in my practice in order to define the daily routine of the patient and put that into context. Again, we will find many surprising and unexpected aspects that can help drive the correct treatment first.
Yeah. And my practice also similar, like yours, Melissa. And the ICS also clearly indicates that the ambulatory urodynamics are secondary diagnostic urodynamic tools for us in certain selected cases, as you have described. The unexplained urgency symptoms or urgency urinary incontinence is one example for that. The problem with ambulatory urodynamics is, of course, the retest reliability is not very high because of the artifacts, because of the movement of the patient, also movement or dislocation of the catheter. So the clinical value is still controversial. Although it is controversial, there is, let's say, a weak level of evidence that it is more sensitive in diagnosing the disorder overactivity compared with the office urodynamics or with ICS standard urodynamics. So I think it's a good research, and I hope in the future we will overcome the difficulties such as catheter dislocation or other artifacts with ambulatory urodynamics. And we will have more precise data and evidence about it. But I think it may be good to have them for selected cases, as you have described.
And the technology, I suspect, is going to advance with incredible rapidity over the next several years, where we will have external monitors, where we will have Bluetooth actuated devices, and immediate feedback even to the patients to be able to help them with behavioral maneuvers that can even decrease their leakage. So it becomes an iterative process, not just for diagnosis, but also for the patient awareness and ability to mitigate some of their symptoms.
Exactly. So this was the case actually, and we are still on for continuing the treatment for the patient, and I will let you know afterwards when we reach the first result.
Perfect.